Hi, my name's Andrew Davidson. I'm from the Royal Children's Hospital in Melbourne, and today I'd like to talk to you about the GAS trial, comparing neurodevelopment after regional and general anesthesia in children. There's plenty of preclinical evidence in animal studies that show that anesthetics affect brain development. There are also some cohort studies that show neonates or infants that have major surgery in infancy have an increased risk of later poor neurobehavioural outcome. However, we do not know if these are separate entities or whether these are related phenomena. One way of answering this question would be to perform a trial. We recently performed the GAS trial, which has been published in The Lancet. In this study, we aim to determine if a short general anaesthetic in infancy is safe. The research question being, does general anaesthesia and awake regional anaesthesia in infancy have the same neurodevelopmental outcome? It was a randomised, assessor-blinded, multi-site equivalence trial run over 7 continents in 26 sites. The general anaesthetic arm had sevoflurane and the regional anaesthetic arm had awake spinal anaesthetic with no sedation. We randomised 722 infants scheduled for inguinal hernia repair less than 60 weeks post-menstrual age. The outcome of interest was the IQ at the age 5 and the Bayley neurodevelopmental score at the age 2. And here I'll present the results for the Bayley at age 2. If we look at some of the demographic data, firstly the duration of surgery was about 26 to 28 minutes and matched across groups. The duration of sevoflurane exposure in the general anaesthesia arm was just under an hour. Interestingly, there was also more hypotension requiring treatment in the general anaesthesia arm. If we look at the outcomes, these are the Bayley scores. And if you look at the columns, the first column is the regional arm with an as-per-protocol analysis. The next column is the general anaesthesia arm with an as-per-protocol analysis. Then the regional arm with an intention-to-treat analysis, and the GA arm with an intention-to-treat analysis. Remember that the Bayley has a mean of 100 and has 5 different subdomains. If you look at all the subdomains, the cognitive, language, motor, socio-emotional, and adaptive behaviour, you can see that the scores are all just under 100. If you then look at the differences, and this is in the as-per-protocol analysis, then you can see that the 95% confidence intervals for all these are very narrow, and they're all within 1/3 of a standard deviation, which was our predefined measure of equivalence, and all the actual differences all being close to 0 and less than 1. So this provides strong evidence for equivalence between the two arms. So in summary, just under an hour of anaesthesia in infancy does not cause clinically significant adverse neurodevelopmental outcome compared to awake regional anaesthesia as measured at 2 years of age. There are some limitations. The duration of exposure was just under an hour, and we know from animal exposure studies that you probably need longer than that to get a significant effect. And also, these are just the interim data for the 2-year outcome. And the 2-year outcome is not a perfect predictor of future function, and we still need to await the 5-year data to be sure there is no difference. The recommendation from this study, along with the other recent evidence, would be not to delay short procedures in infants. We should, however, still consider delaying non-essential lengthy procedures. However, we don't tend to do non-essential lengthy procedures in neonates, and we're still unsure how long that delay should be. And lastly, as anaesthetists, we should not generate a real risk by using an untestable, inadequate anaesthetic to avoid a still largely theoretical risk. Thank you.